welcome everybody. I'll look forward to your questions at the end here. I'm going to go through some of the cases that I've done. I think we're all pretty new to this, but I've done several cases of bearer at this point, and I have some insights that I can share with you based on those. Disclosure, I'm a speaker and consultant for Miach. And important information, I am representing myself with my cases, right? I'm speaking about this procedure and this implant, but these are my cases and my opinions represent me first and foremost. And if you want more information, go to the Miach website. Their team are really transparent. They're very evidence-based. I've really enjoyed working with them. And I guess importantly, I have permission from my patients to share this information with you, which is very kind of them. So just briefly, I'm sure you're all familiar with this science at this point. It's been out for a while. We've all watched Martha Murray have the very last slot at AOSSM on the last day when everybody's already started traveling. But she's worked her way from basic science to clinical justification for this implant, and it's pretty exciting. So the gist is that we think that the problem with ACL healing is that it lacks the fibrin clot that protects the healing ligament like it would in, say, the MCL in an extra-articular setting. And so the goal of the bear is to protect that healing ligament and bridge the gap between the torn ends. That way it resists the synovial enzyme degradation. And by 8 weeks, the implant is replaced with the native cells and the collagen and blood vessels. So you've got these tibial stump sutures that you're going to whip stitch. I'll tell you a little bit more about this in a minute. And that you're going to redirect the torn ACL to its origin. And you've got this cinch suture, we'll call it, to protect the healing ligament while that process is occurring. So this went from animal models to clinical evidence. And in the animal models, the ligament histology was restored in the pig model. And the bear implant proved better than suture alone, that's important, and equal to the ACL graft. And again, the implant is resorbed by 8 weeks. I think that's important for your patients to know. And it has some promise in the sort of post-traumatic OA world. I think we need more clinical information to bear this out, but the rates of post-traumatic OA were lower in the bear patients than in the ACL reconstruction patients, and of course lower than in ACL transection without reconstruction. Clinically, the IKDC is comparable. The AP laxity, instrumented AP laxity, is comparable to a reconstructed ACL, not quite as good as the uninjured ACL. Hamstring strength is superior in the bear, which is not surprising because a lot of the patients in the study had hamstring autograft as their graft. So that is predictable. And then the hamstring quadriceps ratio along those lines. The Coues pain and symptom score were improved, and then the return to sport index at 6 months was improved. So we're seeing that these patients seem to look better and have more confidence earlier on. And contrast that with, we'll talk a little bit about the PT protocol being a bit more conservative at the end of this talk. You guys might have had a hint of that already. I think this sort of helps balance that out, the discomfort that your PTs might have with that discrepancy. So in the Bear 2 trial, so this is the clinical trial looking for non-inferiority, 86% of Bear patients returned to sport, and 70% of ACL reconstruction patients returned to pivoting sports by 1 year. That's actually higher than the general population across the board, but it's nice to see that it's higher in the Bear population. So we think there's something to the preservation of the proprioception of the native ligament that's allowing patients to be confident in their knee. The re-tear rate is in line with sort of the current standard with ACL reconstruction. The Bear re-tear rate compared to their controls was a little bit higher, but not statistically so. And it's comparable to the literature, the Moon and Mars group being the most the prolific contributor to that known number. And in the case of a re-tear, if heaven forbid a Bear patient were to re-tear their ligament, the Miach Corporation has been very rigorous with trying to follow these patients and capture these when possible. And the conversion to a reconstruction, say you do a Bear and the patient goes on to return to sport in a high-risk setting and and re-tear their ACL, that surgery outcome acts more like a primary than a revision ACL, which is very important because we all know that revision ACL outcomes they suffer a great deal. And there's a trend toward fewer contralateral ACL tears. I think we'll all be very interested to know whether that bears out, because Bob Marks, one of my mentors from HSS, would say that he doesn't know which knee to brace if patients want to brace post-ACL because the risk is the same in the contralateral knee. And if that is not the case in the bare procedure, that would be pretty disruptive in the world of ACL surgery. There were no failures to heal in the Bear 2 trial with the post-op MRIs, looking at cross-sectional area, signal intensity, sagittal orientation, trying to make sure that we've got a good product in the end there that's considered to be a functional ligament. And the ACL is restored with the Bear implant in a similar fashion to the uninjured knee, more so than the ACL graft, right, in terms of the size and thickness, which is not surprising because it's their native ligament. You can see this ACL tissue is original quality organization there. So up next is the Bear versus BTB head-to-head randomized controlled study with the Bear Moon group. I think that's going to answer a lot of questions on who should get this and when, and sort of what to expect and finding some trends. But for now, we're understanding that it is not inferior to ACL reconstruction. That's really encouraging. So it's indicated for most ACL tears. I will say that I started with a rigor toward femoral-sided avulsions. I think most people do, just to make sure, beyond a shadow of a doubt, that you have ligament to suture. I have not yet taken it on for a distal tear. I had one that I thought was going to be the case, and my poor rep in town stood there watching our surgery for a long time because it was a multi-lig knee, but the ACL injury turned out to have just a sliver of bone on it, and so it was a tibial spine avulsion, and we treated it as such. But I'm excited to find one that's a tibial-sided and treated in a similar fashion, because it sort of makes intuitive sense. So let's go through the technique here. The patients I'm going to show you are 6 different patients that had Bear ACLs with me. The very first one was only 14. That's the lower end of the studied group of patients. He injured himself in PE. He had surgery a little over a month later. If you talk to him about his sort of level of activity and say, well, you know, what activities do you do? He would say video games. And his family was really, really averse to the idea of surgery. So this was the first surgery that I did with my partner, Dr. Hall, out at the Tuolity satellite that we have in town here. She came to HSU and we collaborated on it. And it was a really great experience because he had this beautiful femoral avulsion. We had lots of ligament to suture. It was always good to do something new with a partner who's skilled. And he so far has been doing really well. And then AC is a 44-year-old skier. MN is, sorry, I'm just going to move this window. Here we go. 48-year-old skier. You're going to see MM is going to come up later on because she was one that got stiff, and I went in for a second look and for a lysis of adhesions. So keep her in mind. And then see if I can advance here. Katie is 23. She's a graduate student who sought me out for this technology because she was very interested in keeping her own tissue and not losing a tendon to this ACL injury that she sustained while skiing. MK was playing soccer, and then EOC was playing pickleball. Pickleball is becoming a pandemic. I'm sure you all are seeing this in your practices too. So the last 2 actually really pushed the limit on timing. So the Bear is studied in up to 50 days post-injury. And both of these patients, one, because I didn't get to meet her, MK, until it was pretty close to the deadline. And the other, EOC, had the once-in-a-lifetime trip with her mother coming up and really wanted to get through that before surgery. And so we did her surgery, I think, literally on day 49. So those I'll highlight a minute later here to give you an idea of what might happen at the later time points. I consider the one that got away, a fellow MD, is a really aggressive heli skier, and he had this beautiful femoral avulsion. He kept saying, "Don't be ageist, like treat me like an elite athlete." And I was saying, well, I'm not being ageist. this is studied in, you know, as young as 14-year-olds, and he didn't want to do anything that wasn't, didn't have long-term data yet, right? So who can blame him for that? So we did a BTB ACL, but I feel like this is the kind of tear that I would love to treat with a bear that's got a nice ligament remnant to suture, very femoral sided injury. And there's something about skiers that they just seem to behave a little differently in terms of the pathology. There's some literature out there that skiers sometimes can be treated non-operatively because they seem to scar in. We think maybe there's a little bit more of a translational component than your average pivoting athlete injury. And so I do find myself kind of hemming and hawing about skiers. So I wonder if bear is going to settle into my favorite thing to do in the skiing population, but I guess time will tell on that one. And then there's one that was an intraop audible. So a 14-year-old football player, his mother is a massage therapist and very much into sort of natural remedies, and came to see me, you know, an hour north of Seattle, drove down to Portland. So she could have seen plenty of surgeons for ACL surgery for her son, but she wanted the most natural thing, which I thought was an interesting comment, because this, you know, it's bovine allograft, and I guess it depends on your definition of natural, but I think that meant that she did not want him to lose a tendon for autograft, and that's a fair request. But you can see on this image that the ligament isn't that easy to see on the MRI in terms of like how much stump do you really have to suture to. And this is the money shot. Like, I couldn't get you any better view than this. So if it were the case that there were more time to work with, it ended up that they came down and saw me, and we rolled it over to surgery the next day. And we had a long conversation about what do we do if it doesn't hold suture, if I don't have enough to work with. And it did not. So I got in there, I was putting suture into the ligament, and each pass it would just sort of pull through, and it wouldn't even hold the Vicryl. And so after several tries of that, I sort of looked over at the rep, and we kind of nodded at each other that we needed to convert this thing. And so we did an autograft quadriceps for him in this case, because he had just enough of an open distal femoral physis that I wanted to keep it soft tissue. But, you know, he came from a family of Hall of Fame football players, and they had all had ACLs with autograft. And so after talking to the mom, she was sad that she'd made that big trip for sort of a standard treatment that she could have gotten closer to home, but she was very understanding about it, and he is doing well. Let's see if I can go back over so the steps, just briefly, you're going to assess your tibial stump and get an idea of how mobile is this thing. Can you get to the torn end of it? Can you redirect it to its origin? Sometimes that's hard work. Sometimes it goes beautifully. I'm beginning to wonder if it's hard to say, oh, it's a timing thing, because I really expected those people that were later in the timeline to be more difficult to mobilize, and only one of the two was. And so there must be something more to it. But you'll get an idea of whether it's mobile, whether it's scarred in, where the end of it is, whether you can get suture into it. And then get an idea of where your footprint is. You're going to be working sort of next to the intact ACL. That gets a little crowded. Sometimes you have to have strategies for that. And then a notchplasty is a standard part of this. And it's not something that's familiar to more recently trained surgeons, I think, because we were sort of trained under the, like, it grows back with an osteophyte sort of worry. But it does correlate with the size of your post-MRI intact ligament. So you really want to make room for this thing. You want to make room to work, make room to see. And so you want to take 2 or 3 millimeters of that notch wall there. So I like to use a curette and just use a shaver on burr mode, and that seems to do the trick nicely. And you just want to keep your back to that ligament and not try to wrap up any of the torn tissue. And then you want to create your tunnels. So this is very familiar to people. I think one of the wonderful things about the bear is that it's sort of company agnostic, right? You can use whatever tools you're used to using to place your tunnels, to pass your sutures. And so you'll see some of the things that I use. The described technique is to be a little anterior to your footprint. I think, so this is me talking, not Miach endorsing this, but the concept of which suture you're using to brace this thing, I think, is important. And I use tape type suture that I do not expect to break. This was studied with Ethibond suture, which is expected to give way as the patients gain flexion. And, you know, an anterior structure is going to be tight in flexion. So it's expected to give way at about 6 weeks as they get to 90 degrees and beyond. But I was I've dabbled before in ACL repair prior to this being publicly available. So as an example, I work at a level 1 trauma center. I had a patient roll in with a traumatic below knee amputation on one side and a bucketed meniscus and ACL tear on the other side. I didn't want to put that guy through an ACL rehab, but I also needed to do something about the bucket. And so we fixed the meniscus and I put the ACL back into the wall of the notch with anchors, and darned if he didn't do really well with that. So I think there's something to it. And when those of us have dabbled with this outside of using the bare graft with its Ethibond sort of technique, the tape type suture is nice and heavy and thought to be a very rigid protector. So if you're going to use a tape and not expect it to break, I sort of worry that if you put it too far anteriorly, you're going to be anisymmetric and capture the knee inflection. So I do tend to be rather central in my tunnel locations. Let's see if I can advance this. There we go. So you can see me with my, I use a flexible guide pin and a flexible sort of curved guide through the anteromedial portal here to place my tunnel. And then on the tibial side, I use a cannulated drill. So a 3mm cannulated drill where you can pass this wire. So if you're going to come up through an intact tibial side, right? Like if it's torn off the femur, you're coming up through the tibial side, you don't have to do that twice. You just come up once, you send your wire, you've got your suture passed. And so I like that way to do it. And then you're going to suture your tibial stump. So you've got your passing sutures in your tunnels. You got to really make sure your suture management is good here so you're not going to get tangled up. But it's actually more straightforward than you might think. If you've never tried this before, I sort of worried that I was going to capture my lateral, because the technique for this is really to make sure that you've got several passes and you don't want to do a whip stitch, as you might think. They describe more of a mattress technique, so you're turning around going the other way. And generally, if you've got good visibility, you've got enough stump to suture, it's very smooth, and you're using number 2 Vicryl, which fits into your standard antegrade suture passer very nicely. It's worth having a cannula here so you can come in and out and not get a tissue bridge. And so that's worth thinking about as well. And then this is the picture of that intra-op audible. So here I was passing suture, and then I would pull on it, and it just ended up fraying the tissue, and it was staring me in the face. And so after several attempts with that, we just deemed it not worth it for the patient and not viable as a surgery, and so converted to a reconstruction. So then, okay, you've got your Vicryl in place. You're going to load that into the button. So that's a purple suture that you see here. So that's going up. And then the button is loaded with your bracing suture. In this case, the picture is 2 strands of Ethibond, so 4 limbs from 2 sutures. And then you've got the drawing sutures for the button, right? And so the button's going to hold your ACL reconstruction in place. You're going to tie that gently, Vicryl tight. Don't break the Vicryl. But it's also suspending your cinching suture to protect this construct. And so then you're going to pass your button, right? So you've got your cinching suture just kind of hanging ready to go. And you've got slack intentionally in your Vicryl, so you're not pulling on that ligament too much. But you've got your button seated on the outer cortex there. And then, yep, there's your cinching suture. And then you're going to thread the cinching sutures through the bare implant. So the bare implant, when you first open it up, it has the consistency of like a kind of dense packing peanut, I would say. So it has a little bit of give, but it's fairly rigid, and a Keith needle goes through it very easily. There's a denser part toward the bottom that you're going to use to sort of send it up in with your thumb, and that you want to keep on the distal side. And so you send these sutures through so that they're going to go through the graft, and then you send those through your tibial tunnel. So then you've got your cinching construct ready to go, and you'll tie a button down below. And then, yep, you can see your button there. And then you're going to hydrate the graft, right? So you're going to go proximal to distal, keep the Vicryl on slack, no pulling on the repair, no risking breaking those Vicryls. And once the bare is hydrated, what we're not showing super well here is that you can kind of scrunch it down to what I would say is the size of like a wine cork. And then you're going to send it up into the notch so that it is what the Vicryl pulls the ACL into. And so this is a video of that. you can see me with the patient's whole blood. So you have the anesthesiologist help you draw some whole blood there when you're ready to go. You don't want it to clot, so you want to do that kind of like in real time when you're ready. And you can see this thing softening. I've learned to hydrate the outsides first before I try to get the inside, just because it becomes soft quickly. And you can see me kind of adding a little bit here, adding it to the bottom part to make sure that that's good and soft. And you can kind of see me start to squish it and test it and make sure that it's ready to go. And you can see 2 tape sutures going through this thing, right? So I'm going to send it in along those tape sutures. So you can see it squishing there. And you've got your arthrotomy ready to go, so you can send this thing up and in. Okay, and then let's see if I can, there we go. So then you're going to send it in. You're going to pull the vicryl gently, right, so that it just approximates that ACL into the bare graft. And generally, it's nice to make your incision laterally over your guide pin before you have sutures you need to dodge. So you tie that suture very carefully over the button up top. And then you tie your cinch sutures down below over the button. And then you're in full extension. You're not allowed to check the logman. You're not allowed to peek because that would wash away the whole blood. And so it's very different than your ACL reconstruction, where like I check the logman, I have the resident check the logman, like check my work, check my work. No peeking, no touching. You don't want to wash that blood away. And so you bring the patient into full extension and place the brace. And so this is one of my bare patients. And so as an example, you can see that my tunnels here are pretty much where you would put a standard ACL tunnel. They're just much smaller. And so you haven't burned a bridge. If you do have a patient that, heaven forbid, has to come back to surgery, you can reuse those tunnels. You can just remove the button in the suture and hopefully away you go. I have not had the pleasure, thankfully. I hope not to have that for a long time. So I have a couple pieces of data to show you guys. The patient that was the graduate student seemed like the most put together person. It truly is, but she had a little too much fun over 4th of July, 3 months post-op, and sustained this fall on a boat that she couldn't really tell me about. She was having less. So her exam was really reassuring. We x-rayed her, and obviously that didn't really show us much. We kind of hemmed and hawed over it for a couple more months, and she was like, well, you know, is there any harm in getting an MRI? And I was like, absolutely not. I would love to get an MRI of this thing. And so this is what it looks like. You can see at 6 months that there are fibers in continuity there. There's some sort of higher signal fibers anteriorly and posteriorly, but there is a ligament going from femur to tibia. And so that's really reassuring, along with her exam that's unchanged. And then here are the 2 patients that I did sort of toward the end of that 50-day window. MK is the 24-year-old soccer player. EOC is the 57-year-old nurse at OHSU who was playing pickleball, who's a really avid pickleball player. It's amazing. She was telling me all about it. So I guess going back for a minute, you can tell already that there's a difference in their MRIs. MK came in with an outside MRI. I feel like that always loses resolution. I can't look at these, though, and really tell you that there's a major difference in them. But I can tell you that MK, and here's a coronal for you just to see if anybody draws any conclusions from that. But MK had a ligament that was super scarred to PCL that I had to work really hard to mobilize. And I was frankly kind of worried at the beginning that it wasn't going to mobilize, but with some TLC and kind of keeping my back to PCL and given a nice lever with various tools, I think I ended up using some of the shoulder tools to just sort of get in that space and kind of wiggle it away. You don't want to be sharp about it. You just want to have kind of a paddle. And so like a freer, I think we might have opened an ortho minor and gotten a freer elevator, that kind of thing. But it mobilized well in the end. It just took a whole lot of work to do it. And so then when EOC came along, I was worried that that was going to happen again, but no such thing. It was very much a different bear, and no pun intended. And I had to just sort of pull it away from the scar that started to form. That was easy to do, kind of peel it off the wall. So I can't tell you that I can draw any patterns from these 2, but I can tell you they're different. These are apples and oranges, and I don't think I could say that, oh, beware the patient at 45 plus days based on these 2 patients. And I think that's a good thing. I think that's why it was studied in this time frame, in that sort of acute inflammation phase. And then I had one patient undergo manipulation, as I mentioned. So she had surgery fairly soon after the injury. She was one of my skiers. She has this history of Gilbert syndrome, which is a difficulty processing bilirubin in the liver. I don't know if that has anything to do with it. I do kind of wonder if she's predisposed to stiffness a little bit. But she was one in the early period that I was a little bit worried about the fact that, like, you guys have seen ACLs, you've seen them have these flexion contractures at first when the torn ligament balls up in the notch, they have trouble with full extension. And I was starting with an even more conservative protocol than is described in the PT protocol that was studied, because I was thinking, well, keep them in extension for 2 weeks straight. What is described is keep them in extension overnight and then start 0 to 30. But I learned quickly that, for one thing, that doesn't always work. Patients can sit in slight flexion even in a brace, as I'm sure you all know, and they, as much as I read on the Riot Act, they still didn't necessarily get that full extension in the 2 weeks as I was hoping. So unless I just make them hang prone off the end of their bed, I'm not sure that would do much for me. So I've converted to the standard protocol at this point. But she got like 5 to 85 by a little over 3 months post-op. And my sort of internal barometer is like, are you making it to 90 and beyond? So we kind of dragged our feet a little bit. And she, by 5 months post-op, had gone to 105 and kind of leveled off and wasn't really making much progress and was frankly kind of frustrated about it. So I asked her if I could have permission to go and lyse adhesions and manipulate. And if it's, 3 months or so, I think plain old manipulation is kind of reasonable. But I really wanted to look at this thing. And it was 5 months, not 3 months. And so I went in and looked, and the suprapatellar pouch was sort of walled off. So I was glad I didn't try to inject it and try to jumpstart it that way. So I released a bunch of adhesions, and then the MUA went very smoothly once the scar was released. And this is what it looked like. So this is the notch. And you can see the ligament there with some really nice blood vessels, some scar kind of hanging over it. I didn't really want to get too close to it and disrupt the native ligament, but it was rock solid on exam. I'm sure some of you in the audience have seen these patients who get stiff really benefit from the stability of that. So she's no exception. She's super happy with it at this point. It was just that sort of hiccup that she had to get this second procedure done. So the post-op protocol, you want to do partial weight bearing at first. Like I mentioned, the first couple weeks you're 0 to 30, then you advance by 30 degrees until you get to 90. And then they want you to switch from a post-op brace to a functional knee brace. That's been a little bit of an adventure with my patients. It takes a little while to get that. And so I'm trying to figure out the timing of ordering it. And I don't want to relegate patients to the post-op knee brace, because at some point it starts to hold them back rather than helping. But I think you'll see from Miach in the near future an updated protocol, because they have gotten some feedback from the PTs that they've worked with and some of the surgeons that they've been in contact with, that this does seem like it might be too conservative. But keep in mind that 6-month time point in the data that they feel more confident in their knee, and their functional outcome scores are better. So despite all the difference in the post-op initial period, it does seem to really have an accelerated return to, I guess, confidence in the knee. And so hopefully we'll get some more clinical data to back that up as people continue to study this thing. I think that's it about the P2 protocol. Of note, all the patients get this cute little bear and they really love it. I think it's a nice touch. And then I'm happy to answer any questions that you guys have. It looks like we've got a couple of them in the box here. So maybe let's see, I'm going to stop sharing for a minute and I'm going to go to the Q&A. So as you've gained more experience with Bear, how have the types of patients, age, activity, tear type, et cetera, you offer Bear to evolved? I've been trying to be pretty egalitarian about it. I've had a range of patients. I did approach Dr. Spindler, who runs the Moon and the Mars trials and heads up the Bear Moon study. And I asked him what he does with his collegiate athletes. And he said, well, he offers it per protocol, but he does not encourage it because we don't know yet sort of how to return collegiate athletes to sport with this thing and how it sort of behaves over time. So I haven't really pushed it with collegiate athletes either, but I mean, I had a professional martial artist who had just injured himself, and he was opening his martial arts gym, and there was sort of a lot on the line. And he elected not to do the Bear in large part because of timing, because he was trying to get his martial arts gym open and needed to delay his surgery for that reason. But we had a frank conversation about it. And so I think I can offer it with relative confidence to anybody that I think I can suture that ligament. I think that's the key, is can you get suture in that ligament? So what do you see on that MRI? And the more doubt you have, I think the more you have to talk about a backup plan. And then how do you present BEAR as an option to your patients? So I usually lead with that. I tell them, you know, there's this relatively new thing. It's out there on the market, and it's pretty exciting. We don't know as much long-term about it, but it spares you a tendon. And if for some reason the knee is re-injured, it behaves much like a sort of first time around ACL surgery. And I think that is a pretty frank conversation. Some people are really interested in it based on the fact that they don't have to lose their own tendon, and some people are a little bit more skeptical. I am very biased against allograft ACL reconstruction, like hamstring allograft, because my population does tend to be a bit younger. I treat a lot of instability. I'm a team doc for a college. And so honestly, by the time I'm thinking about sort of the historical allograft reconstruction, I'm kind of wondering if I should be doing it at all, because we know that the failure rates are higher. And so that's not something that I push. I've had some patients do well with allograft, and I think it's still a reasonable option in some populations. But I think patients like the idea of not losing their own tendon and keeping their proprioception, and that's sort of the conversation we have. And honestly, a lot of them come to us. Like the word is out. The Wall Street Journal had that article about it, and patients are coming and asking to know about it. I don't know if you guys in the audience have had that. And then somebody said there's an updated protocol coming out that is a little more progressive and closer to what we're doing with reconstructions. I agree. I've not seen that protocol, but I will say that their PTs have been, the Miach team's PTs and the PTs who helped Dr. Murray study this thing have been incredibly transparent and communicative. And when we have questions about the nuances of their protocol, my PTs email them and they get an answer back, and they talk it through. So I encourage you guys to do the same thing. Young patients with wide open physes. So of note, I don't believe that this is sort of an official approved indication. This is on paper a procedure you do for 14 and up with closed physes. But I know a lot of us are excited about it for the prospect of not injuring the physes. And so in the 14-year-old that I described as the intraop audible that we converted to a quad, I did actually duck underneath the physis and do an all epiphyseal femoral side, because he was just open enough that I was not loving the idea of crossing that physis. So I think there's promise. I don't think I can officially recommend it. I don't have a whole lot of experience in the wide open physes. If they're super small and wide open physes, I've done a couple of IT band reconstructions with one of my peds partners, and I think that procedure has a lot of promise too. So all options are on the table, I think, at that point. Add lateral extra-articular tenodesis. That's a great question. I have not yet added a lateral extra-articular tenodesis to a BEAR. I think it's a very reasonable thing to think about in especially the young, like the adolescent hyperlax female athlete. That seems to be the sort of indication for adding it to a standard ACL recon in a lot of cases. I have not had that come up yet, though. But I think that would be when I would think about it. And then same degree of quad atrophy. I think that's a good question. I have actually been pleasantly surprised. I think in my practice, the quad ACL autograft has the highest degree of sort of quad dysfunction on the front end, and BEAR definitely beats that one. But it is a slow rehab, and so their return to sort of normal function is slower just by the fact that we're making them partial weight bearing. I've seen them bounce back nicely, though. I don't think it's one of these where you're sort of worried that this more conservative front end is going to delay their quad function once we do turn them loose. I think it's more on the order of like if you have a meniscus repair that you're protecting, that sort of thing. With internal brace, Lockman will always feel solid. How should that last? So if an internal brace is placed with an ACL, the Lockman will always feel solid. That's a good question. I mean, I've had like all inside PCLs where I'll add an internal brace. That I reviewed a paper for AJSM. I'm not sure if we actually ended up letting it through versus OJSM. That was one surgeon's 20-year experience with a bracing suture with his PCLs versus not overseas. It was very rigorously done, very nicely done. And he did have the internal brace did edge it out. So I started adding an internal brace to my PCL soft tissue reconstructions. And I will say that those don't always have a completely solid posterior drawer, as PCLs often break our hearts and do. So I'm not sure that's abundantly true. But you're right, it's a very strong bracing suture. And I don't think it could fool you, though, over months and months of rehab to hold up to like the rigors of sports surgery. I guess I would need data to back that up, though. I think if it's going to be lax, it's going to be lax whether you have an internal brace or not. But I really like the tape suture as an initial protector as opposed to an Ethibond, because I just find Ethibond to be a little bit too easy to break with my bare hands. But that's me. That's not the Miach technique. Percentage of bears versus other grafts. So I've done 6 bear surgeries. I've had one that we intended to do and audibled. I've had a couple multi-lig knees where we've been dealing with some big juicy fibular avulsion in a posterolateral corner. And we're sort of wondering if we could get away with a bear for the ACL instead of having to do a reconstruction. But the one that I mentioned was a tibial spine in the end, and the other was just so very, very synovitic, and the surgery had taken so very long for the posterolateral corner that I was collaborating with my colleague, and it was his patient, and he just was not comfortable operating on that ACL. So stand by for more on that. I think there is more to come. In terms of overall numbers, I guess I don't know that off the top of my head. It's still the minority. It's certainly still the minority. And I think some patients are really into the concept and some patients are not. And a lot of times, unfortunately, the holdup is timing. Like, I think if this becomes a competitor, as it seems like it's getting there, then we really need a fracture model for ACL care. Like, I need access to my OR sooner. I need like a trauma room for ACLs, which I think my trauma partners would laugh at right now. But if we really prove this thing to be as viable as BTB autograft in like my collegiate football player, then I think we're going to need to change the way that we get the patients to our clinic from the ED, because sometimes they just don't get to me soon enough for it to be on the table as an option. And then one person asked, can I clarify the vicryl stitches? So yes, after passing through the stump, you load it into the femoral button and don't tension or tie until the bear is in. That is correct. So the vicryl stitches, you sort of pass them upwards through the button, and you've got that stitch going up and through your tunnel, but you're keeping a clamp on it so that you don't have all the slack out of the system. So if you saw suture sticking out of the portal on the diagram that was purple, that was the loop. So the ends are already up through the tunnel. You're going to tie those over your button, but you're keeping a clamp on the loop so that you don't have too much tension on the sutures up top. And I would recommend that not be a traumatic clamp, right? You don't want to have like just a mosquito. You want to have like a non-penetrating towel clip type of deal. And then once your bear graft is in, then you take the slack out via the ends of suture and tie those ends together. But the ends have been out of the tunnel for some time at that point. Please write back if that didn't answer your question. And then 19-year-old varsity college soccer player female wants to be back next season. Would you offer bear? That's a great question. I mean, based on the literature, it should be possible, right? Like, they feel better sooner. They seem to have better strength potentially. And I think that should be an option. I personally haven't pushed it for my collegiate athletes, in part because we don't have a study of collegiate athletes with bear. We don't have a study of elite athletes with bear. And I think that's what the Bear Moon study is going to give us, is that head-to-head comparison via, or sort of compared to my gold standard in football players, for instance. In soccer players, my gold standard is still patellar tendon. I know a lot of people are loving quad, and I don't fault them for that, but I love the bone healing into bone and the predictability of that. So I don't know. I'd be interested to hear sort of high volume user of bear and their thought on the collegiate athlete and sort of level competitor, because I think we're getting there. I just think it's hard to take the leap in that high stakes situation where I mean, oftentimes like you're talking, 9 months to a year, they didn't tear it on the first day of their season. So you're sort of pushing the envelope timeline wise, and it's good to go with what I think, in the collegiate athlete setting. But what's the reason I haven't done it? I couldn't really tell you other than that. I think we just need more data. And I think we're gonna get it. We're gonna get it soon because those studies are underway. Top benefits to me and my practice by offering bear. That's a great question. What are the top benefits to me and my practice? So I think the top benefit is to the patient, to save their ligament, to save the proprioception there, to spare them losing a tendon. I do think this is a bit quicker. There is some fiddle factor to making sure that you have enough room to work, you're in front of your native ligament. It's a little more crowded than you're used to with a reconstruction, but it's faster. It saves you some minutes in the OR, and that's worth something. But I think the benefit is to the patient and not necessarily my practice. I think there's utility in being able to offer this thing that's new and exciting and important for patients to have as an option. But beyond that, I really think the benefits to the patient. We all know meniscus healing rates are much higher in the setting of concomitant ACL reconstruction. In your experience, are the meniscus repair healing rates the same for bear? So great question. I probably don't have the level of experience to answer that question directly. I can tell you that a couple of the bear patients did have concomitant meniscus procedures. One was a root repair, and one was a more standard like medial meniscus tear repair, and they both seem to have healed clinically very well. I do not make it a standard to get a post-operative MRI to try to suss that out. I'm sure, as you know, that the signal in the meniscus can be confounding anyway, if it's like fibrous union or post-operative changes versus like a re-tear. And so I think it just muddies the waters to try to evaluate your meniscus pathology. But clinically speaking, they have held up just fine. And I think if your lockment is comparable and your stability of your knee is comparable, they should hold up fine. And I guess if your question is more on the basic science of are we bringing in the same sort of good humors of the bleeding bone and the factors that we think are contributing to the science of meniscus healing, I would argue yes, because we're still drilling into the bone. But yeah, that's an interesting question. It would be really good to see that be the case as well, and make sure that those numbers are the same. Is there a significant difference in cost or charges for the bear versus standard ACL reconstruction? So I can tell you that when I tried to get this into my hospital via the sort of VAC committee, I'm sure you guys all have versions of that at your hospitals. The main thing they wanted to know was, will insurance reimburse it? And in my world, it reimburses as an allograft. It is not a separate code. You don't have some like sort of other code that you're coding for. It's just a hamstring reconstruction with allograft. And so in terms of the cost of the thing, I think you have to talk to your rep and sort of rely on your hospital's contracting model to really get a number on that. But I think in terms of getting it into your hospital, from my hospital standpoint, it was very smooth. I was surprised at how smooth it was, because for other things, it's been harder to get them in the door. And then, do you plan on getting an MRI on every bear? And if so, at what time point? That is a great question. I think I would love to get an MRI on every bear. I think if I were to do that in standard fashion, I would probably pick 1 year. I have not yet done that. I'm a little bit torn on sort of utilization of resources versus academia, and sort of being a student of my own practice. But it's a fair question. I think it's a very reasonable thing to do, especially in something new. But I think other studies will do that. I'd have to look up the Bear Moon group on whether they're going to get post-op MRIs. I sure hope so. But I rely heavily on the physical exam and sort of how the patient's feeling about things. I was sure glad to get it on the one patient who wanted it, though. So I'm going to rethink that and maybe circle back. The most time post-op is that patient that is my partner's patient at the satellite hospital. So I might ping her and see if we can circle back on that. It's a fair question. And I think that's the end of the list right now. Does anybody else have any questions to throw at me? Yeah. One of the Miach folks is chiming in for reimbursement. It's an implant that's reimbursed as an implant, similar to any anchor or screw in a standard ACL. Yeah, that's well put. Any other questions? Oh yeah, it may make sense to get an MRI to consider return to sport. That is fair. Yeah, if you're thinking about, we were actually talking before the webinar started about the NFL Combine, and I think that will absolutely be a thing if collegiate football players start getting bare grafts on a regular basis, or if any of them do, they'll probably just get scanned on their way to the Combine. Oh, great question. One doc wants to know any idea of total volume done so far in the US. Joe or any of the Miach folks, do you have any idea on that?
Yeah, I would say, this is Joe, about over 500 to date implants.
Gotcha. And then what are the re-tear rates? I know there's not long-term data, but with what is currently known. So in the Bear 2 trial, the rate of failure was 14%. I don't know if we have any updated data on the longer term follow-up. I know that the oh, and are those 500 being tracked? So Miach has a registry. One of the reasons I approached Dr. Spindler was to try to convince him to let me into the Bear Moon trial, and he slightly declined, understandably. But Miach has a registry that they're trying to follow people along the way, and they're keeping very close tabs on whether you know, surgery takes longer or shorter, and sort of how things go, and a whole lot of detail. So I think their rigor is encouraging, and I think more will come out of that. Like the prospective cohort, I think is useful in some ways, and the randomized head-to-head trial will be useful in others, and I think those will be very complementary. Did the biopsies come from the sponge interface? I'm not sure I understand that question. If you can elaborate. Biopsies of, are we talking like the pig studies? I'm not sure what that question means. So the biopsies of the sponge interface, I'm thinking the Bear graft. I guess while we're waiting for any elaboration on that, I was going to mention that Joe was reminding me that in the pig studies, nobody was braced, right? So like the post-operative rehab, I think we can get more aggressive with that in mind. Although pigs, you know, they walk on 4 legs instead of humans walking on 2. So that sort of gives me hope that we can be a little bit more aggressive. Oh, here we go. Okay, so they did biopsies in the pig studies and the pathology looked amazing. Gotcha. Curious if this was just a biopsy of the ACL stump or if they actually got biopsies of the sponge interface at the healing site. I believe it was like a cross-sectional area of the healing site, which they put on a slide to look at the histology of the area where it was torn in the first place. And then, would you ever do a luggage tag type suture on your ACL stump? I don't have any problem with that, honestly. I think this suture is just a suture to direct the ligament into its home. As long as you're confident that that thing is not going to pull out, I don't have any problem with it. I tend to be a little conservative on sticking with the technique and sticking with the protocol. I have a lot of trust in Martha Murray's data and what she's rigorously studied. And so I tend to stick with her technique in every way, except for, I guess, where I'm putting my tunnels and where I'm, what I'm using to brace the thing. But I tend to use the mattress type suture just because that's how she studied it. I think that makes a lot of sense to me. But the luggage tag is certainly a thing that we're using in other arenas. And if you're confident in the hold on that thing, maybe give it a Vicryl tug and just make sure that it's going to hold. I don't see why that wouldn't work, as long as you're doing what you intended to do in terms of directing that thing back up to its home.